Thank you. Great. Thank you, Greg, and the organizing committee for the invitation to come speak to you. In my personal travels or academic travels, I've been to, I think, every part of the country and given talks or visited for personal reasons. I think Seattle was one of the only places I had not been to, and I've been saying that for many years. So thank you for helping me check that box as well. I think I've been to most major cities. So as we get started, since this is the first talk, I'm not just going to dive right into how do you do a maxillary sinus. Everybody here knows how to do that. How do you do ethmoid work? Well, most people do that. I will go through some of the finer nuances, the technical nuances as I see them, but also try to put this in a little bit broader context of what surgery actually means. Because it's not just about being able to create a hole or to rip out an ethmoid partition. I think we know that all the science behind the pathophysiology of chronic rhinosinusitis, we got to look at the broader picture of what we are. So these are my disclosures. And this is a statement that was uttered, you can see, 1929 by Mosher. If it were placed in any other part of the body, the ethmoid would be an insignificant and harmless collection of bony cells. In the place where nature has put it, diseases and surgery of the labyrinth often lead to tragedy. Any surgery in this region should be simple, but it has proven to be one of the easiest ways to kill a patient. I'm glad to tell you that we've come an incredibly long way since those initial words were uttered. Sinus surgery in 2015 is very safe, but disaster can still strike. I would stress that surgical mastery is truly a lifelong process. I don't do a lot of primary work, and I had to find, a case, and I had to tell my resident, I'm actually going to have to do the side because I got to take a little bit of video for a course that I'm going to. But I have to tell you, as I watched the video, I was like, why did I do that? And actually, if you watch your own work, that's a great way to get better when you watch it later on. But there's really 4 key phases to FACS, and you will, in your practice, have patients that are in these different buckets, if you will. You have patients that are coming in for their initial evaluation, and you're optimizing them. You're helping them make the decision, are they just going to need medical work, accurate diagnosis? And if you are going to go the route of surgery, really formulating a clear plan and then understanding what it is you're going to accomplish based on their imaging and endoscopy. Then really the goal that Greg has asked me is to really talk about the intraoperative surgical execution of the maxillary and ethmoid sinuses, but your work doesn't stop there. You can do the best work in the OR, but if you don't have a commitment to good post-op care and then lifelong, surveillance and medical management, it just doesn't work that well. That's just the reality of it. And frankly, in a purely rhinology practice, most of my patients are in number 4. Yes, I'm evaluating patients every week, new patients that I see. Some are going down the algorithm of surgery, but the ones that I operate on, they're all in number 4. And that's really probably 2/3 to 3/4 of my practice. I'm not getting rid of them. Once I operate on them, you have to own them. The other thing is really aligning the goals of surgery. It's more than just establishing quote-unquote ventilation and drainage. It's really reducing the inflammatory load, whether it's polyps, osteotic partitions, debriding the sinuses to remove all that thick inspissated debris that you see there, and then really creating an environment that's going to facilitate optimal delivery of topical therapies, whether they're physician-directed. I'm showing you placement of a mometazone gel in a patient who is relapsing after surgery in my hands, or whether it's patient-directed therapies like high-dose topical steroid irrigations that many of us have incorporated into our practice. And then last but not least, really helping enhance diagnosis. Richard Harvey has come up with a great histopathology criteria that he uses. It's about 8 or 10 things, and we've actually incorporated that into our practice. So everybody that has surgery for chronic rhinosinusitis in my practice, we get this spreadsheet of how many eosinophils, basement membrane thickening, variety of other things. And we don't know how we're going to use that, but right now we're collecting that data, and down the road, we'll be able to do post hoc analysis to see which one of those factors are really critical in predicting how these patients do. So this is the checklist, and I'll go through a little bit of this because I think more important than the actual surgery is knowing the plan and knowing the different variations and things that you ought to be looking for. And really the most key thing for maxillary sinus surgery is looking at the rotation of the uncinate relative to the orbit. And then for ethmoid surgery, shape and integrity of the skull base, the position of really the anterior ethmoid artery is critical, shape and integrity of the orbit, and then height of the posterior ethmoid relative to the maxillary. And I'll show you what that means as well. And then the sphenoid things are really going to be more relevant for Don's talk. I think it's the perioperative considerations are critical, optimizing the patient, optimizing the nose. Both of those things ought to happen concurrently. Optimizing asthma, making sure their blood pressure is good, and then as far as tobacco, although there's some data to suggest, well, it really doesn't matter, I think it absolutely does, and we really work hard to see if these patients can stop smoking. I have elected not to operate on patients if they are not willing to quit or if they're heavy smokers. And then really optimizing the mucosal disease as much as possible in that perioperative period, utilizing antibiotics, oral steroids. This will help you with your surgery intraoperatively. And then actually, Aaron Wright's data shows this may actually help the post-op mucosal healing as well. If somebody shows up to the OR and they forgot to take their steroids, I will probably cancel them. If it's truly elective surgery, you can always live to do this another day and get a better result. Key anesthetic considerations, head of bed elevation is critical. It's actually a reverse Trendelenburg position. The head has to be up, feet have to be down. And just doing that 20 degrees can actually reduce your mean arterial pressure without really compromising cardiac output or heart rate. I have colleagues that used to sit that now stand because they want the head up so high. I have not made the transition. I still like to sit when I operate, but this is a critical part of it. And then working with your anesthesiologist, Warmold's data has shown that the surgical field is better when you use TIVA and really trying to keep the heart rate down as much as possible. Another important change that I've made in my practice is I almost never do injections anymore. It's all topical epi. And actually, my surgical field has never been better. It's been a remarkable change. You'll notice the pledgets I'm putting there have a subtle green hue to them. Using fluorescein is critical. You don't want to, if you do have injections up, you don't want to inject 1 to 1,000 epinephrine in a patient's nose. And you can see from Richard Orlandi's study of almost 2,000 cases, they had 2 complications, and one was because the scrub across from him handed him an injection of this topical epi. So I actually don't have any injections up, but I still use the fluorescein to color this. So a little bit on maxillary antrostomy. Again, the position of the uncinate is most critical here. As you can see here, most commonly, it's going to turn laterally and attach to the orbit, and that in turn will form the relationship with the frontal recess. In these cases, the frontal is going to drain more medial, but it can go straight up and attach the skull base, or can rotate medially and attach the middle turbinate. There's been some interesting data out of the UK, which has shown that actually you can have multiple attachment points, so the uncinate can fan out, and sometimes a portion of it can attach to the orbit, and some of it can attach to the skull base as well. So it's not that it will always consistently, all of it will attach to one area. The most critical thing to keep in mind is this issue of an atelectatic infundibulum, where the uncinate process is rotated laterally and plastered to the orbit. This is often seen in the sinus, in the setting of silent sinus syndrome. This really can put the orbit at risk. I gave this talk, I talked about this concept many times, but I remember when I gave it about 2006 or 7, and I walked off the podium and somebody walked up to me and said, I wish I would have heard this talk last week. I just did the exact same thing you had warned about in this talk. You can see in this postoperative result, the orbit is way down into the orbit, and it would be very easy to penetrate that. So this is the most critical thing you need to think about. The other thing is the lacrimal duct. You know, often the classic teaching is use your backbiter, keep coming anteriorly until you hear that hard crunch of the bone, and then you know you can stop because now you're at the lacrimal bone. Well, it's not always so forgiving. The mean thickness of the lacrimal bone is actually 0.1 millimeters. So it's not all that thick, and it can be dehiscent. So really, either using image guidance or anatomic cues, you ought to be thinking exactly where that lacrimal system is, as opposed to just coming aggressively anteriorly. The other thing to think about is the infraorbital ethmoid cell, and these are called Haller cells, intimately associated with the infundibulum of the maxillary sinus. Most of these are right here next to the natural ostium. I'm going to show you some video of this being taken down. So these are the key steps. This should all be in the PDF handout that I provided. Really identification of the maxillary line, complete removal of the uncinate, accurate identification of the natural ostium, which I personally don't think it's possible unless you use a 70, but I think you could probably get away with a 45, and then really establishing this pear-shaped opening or an ovoid opening. If you have a circular opening, you can almost be certain that you've created a dual ostia configuration. And then the optimal size truly is unknown. So we pick up live action in surgery here. Again, identifying that maxillary line, that's where the uncinate process attaches to the ascending process of the maxilla. So you know the lacrimal system is going to be anterior to that. Probing into the infundibulum, ethmoid infundibulum, and then using a pediatric backbiter and just taking little bites to come anteriorly. So you can see there's actually quite a bit of uncinate to remove there. The technique that I'm showing you is a technique that has been advocated by Fred Kuhn for doing the uncinectomy, creating a window initially in the uncinate process and then rotating this from a sagittal to a coronal orientation, and then using a 90-degree Blakesley forceps and using the push-pull techniques. And this really disarticulates this from the ascending process of the maxilla. And often you can get all of that out in a single bite. And then now I've switched to a 30-degree telescope. I use reverse scopes in my practice. I think that's extremely helpful, especially for frontal surgery. And then really disarticulating a little portion of that uncinate, the inferior uncinate, and then we're going to take that down, working posteriorly, using straight through-cutting forceps, and then using a backbiter to take some of that residual uncinate anteriorly. So this is a hybrid technique in the sense that I'm using a combination of through-cutting tools, plus I'm also using, I will be using the shaver as well. Shaver's great for cleaning up little edges, but I don't try to take big pieces of bone with that. For the sake of time, I'm going to move ahead a little bit. So once we clear out, now I'm working with a 70-degree scope, you'll see this huge bulge here. And that's that infraorbital ethmoid air cell, and it's going to blunt the view to the natural ostium. We don't have great tools to take these out. You can use a 90 Blakesley forceps, you can use a 45-degree through-cutting forceps, but usually the medial wall of that cell, I'm trying to remove with a variety of different tools. And in each patient, it's always a little bit different. Usually the lateral wall of it, unless it's causing any issues, I leave that alone. So this is what you want your maxillary sinus intraoperative to look like. This is the natural ostium looking with a 70-degree scope, looking into the infraorbital ethmoid cell, and then again that long, elongated, pear-shaped opening. These are a couple of patients that I've revised. You can see again, retained uncinate process. This is the most common reason, I would say, for failure, because if you don't take that down, you're going to end up with a dual ostia. And sure enough, when you take down that uncinate process, you can see this bridge of tissue and the mucus is recirculating around that. And you take that bridge of tissue out, you've essentially fixed that patient. This is a patient I took care of 2 or 3 years ago. This is a little more interesting and more complex. There's a dual ostia right there, but this patient is also recirculating around the inferior meatus, because you'll notice in a second here that there's actually a punched out opening. There's an inferior antral window as well. So here, I had to do almost a medial maxillectomy, take out that central segment of the inferior turbinate, essentially connecting the 3 dots there, but then that's also somebody you can fix. This is an old study by Kuntakis, but I still really like the study because it shows kind of the common pitfalls of why we fail. And you can see that retained Uncinate process in their revision cases was noted in almost 40% of the cases. Moving on to ethmoidectomy, just a few key anatomic things that I want to mention here. Keros was a Croatian anatomist, and this is his contribution to rhinology, and that is the Keros classification for depth of the olfactory fossa. So the numbers to keep in mind are 4 and 7. Anything less than that is type 1. Anything greater than 7 is type 3. And the key is that the shallower that olfactory fossa, the deeper it is, the higher the risk of injury to the skull base. These are patients of mine who show you the Keros 1, 2, and 3 configuration. But what Keros didn't take into account was the fact that most patients don't have exact symmetry on both sides. And we've looked at this issue many, many years ago when I was at the Cleveland Clinic, and we looked at 50 sides in patients having surgery, and turns out all 50 sides are actually asymmetric. So nobody's skull base is exactly at the same height on both sides. You can see this patient here with a mucocele after resection of a middle turbinate. You can see the difference in the configuration. This is essentially just a cribiform plate going all the way up. And this configuration is, some have called it the horizontal lateral vermella. Again, keep in mind that the bone is always going to be the thinnest, where the anterior ethmoid artery goes into the ethmoidal sulcus, into the olfactory fossa. Kynes and Stamberger have measured the thickness of this bone here to be less than 0.5 millimeter. I think maybe even 1/10 of that. The other key thing is, remember, the orbit is not a perfect circle. Depending on where you encounter the orbit and the lacrimal system in the nose, this can be very different. So if you're all the way anterior by the lacrimal system, it's actually going to jut out into your field. Take a look at patients that have polyps or tumors. This is the first area that gets eroded because it's the narrowest space there. Mid-orbit, it tends to be relatively flat. So you have almost a straight working line, and it's in the posterior ethmoid where it's actually going away from you. And that's where you have the most working room to do your ethmoid work, or at least identify the skull base and the orbit initially. The other thing to keep in mind is that the medial rectus, the position of this, changes when you go from anterior to posterior. And I've taken care of patients who've had orbital injury sent to me, and if there's an injury up here, there's a relatively large fat pad. So it's forgiving. But if that injury happens in the orbital apex, there's almost no fat there, and any minor manipulation is much less forgiving. Remember that the orbit will have dehiscences. Many of these happen due to disease, but often there are natural dehiscences of the lamina papricia. And this is a large study of more than 1,000 patients from South Korea that looked at this. And turns out that orbital prolapse into the ethmoid was noted in 6.5%, which is not really an insignificant number. And in a third of those cases, it was enough to deform the medial rectus into that field. The last concept that I wanted to mention was the height of the posterior ethmoid relative to the maxillary. The greater the pneumatization here, less the working room there. And you can see this is a patient with a very shallow posterior ethmoid roof. She was sent to me after somebody went right through the skull base, high entry into the basal lamella, and developed a CSF leak. So the key points here are, I'm sorry, I'm going to run out of time here, are complete removal of the ethmoid bulla, low entry into the basal lamella, and careful identification of the skull base and the posterior ethmoid, and then really completely skeletonizing the orbit, completely skeletonizing the skull base. You can't shy away from those areas. If you want to do complete ethmoid surgery, it's critical to do that. And the other thing is to really avoid mucosal stripping. So I just want to skip ahead a little bit. There's one key thing that I want to show you. The 45-degree through-cutting forceps is really your friend when you're doing ethmoid surgery. What I do is I feel behind these partitions, figure out exactly how much depth I have, and then you can essentially do majority of your dissection with a 45-degree through-cutting forceps. Again, skeletonizing the orbit here, and using the same tool to do that. And then if I get little tiny shards of bone, then I can use a shaver to clean up those raw edges. I just want to make one additional point. Not all ethmoidectomy is ethmoidectomy. You can do incomplete surgery, which is the most common thing that I revise. So this is a patient who's had ethmoid surgery, but severe frontal and ethmoid disease and incredible amount of disease that's still left behind. They essentially cleared out the very lowest part of the nose, but all the disease at the orbit and skull base is there. Way too much surgery. The septum is gone, all the turbinates are gone. Patient had a normal scan when they started. So, it's not just about being able to take everything out. It's respecting the structures and the boundaries adjacent to it. And again, I just want to underscore a critical point. This is the initial step, and then really postoperative care. So if there's two key things that I can impart on you about maxillary and ethmoid surgery, identifying the natural ostium is the most critical thing. And number two, when you're doing the ethmoidectomy, it's got to be a full, complete dissection. You've got to be able to see the entire orbit. You have to be able to see the entire skull base, because that's going to give you the maximal reduction of the mucosal and bony disease and hopefully give this patient a chance to do well. I'll try to come back to some of these concepts during the dissection. Sorry, I'm out of time. Thank you.
Thanks, Pete. Really appreciate that. Any questions for Dr. Batra while Dr. Lanza is setting up? Well, I do just want to highlight one of your key points, Pete, was mucosal preservation. We all talk about it, but what does that really mean? To me, when I'm taking my residents through cases, as they get to be a senior or chief resident, if I see exposed bone, I literally spaz out. My heart starts palpitating, I start sweating and get really frustrated. That's, to me, what separates, in addition to doing complete surgery, that's to me what separates a novice surgeon from an expert surgeon, is preserving that mucosa. Not having any exposed bone, unless you're doing a draft 3, it's one extra attention to detail that's key. If you have little fragments of bone, pull it out. Don't leave it there. Don't expect the saline irrigation to wash it out. Get all those little fragments out meticulously, and it's just so important to not have exposed bone. So if you do see exposed bone, most of the time you can take that bone, unless it's right on the lateral wall. So keep that in mind. All right.